This conference will now be recorded.
So I welcome all of you, and I hope and I welcome the whole audience, the whole members who are joining us, and I hope that they enjoy this webinar. And it is my pleasant duty as a president of IFAS to welcome all the delegates as well as the participants. So if Dr. Rajiv Shah has joined or not, sir, can you hear me, Dr. Rajiv Shah? I don't think so. So can we start with the first talk? Can we start with the first talk from Malhar Dave, which is on the pathoanatomy of the ankle malunion?
Yes. Yes, sir.
Yeah. Can you put him on the screen? And Dr. Indrajit, I would request you to just note the questions.
Yes, sir, I am.
Yes, okay. So can you ask Malhar to start his talk? Hi, Malhar, can you hear me? Malhar. Indrajit?
So he is joining in 1 second, sir. He's starting it, sir.
Okay. Oh, okay. That's great. So I think Dr. Sampath has got the next one. Dr. Sampath, are you ready with it?
Yes.
That's great. That's great. Yours is on reconstruction.
Yeah.
He's supposed to. He's not able to unmute.
Hello.
Yes, Malhar sir, we can hear you.
Hello.
Malhar, can you hear us?
Hello.
His network is bad, sir. He can hear us, but there's a delay.
So can we start with the first with Dr. Sampath?
I think so, yes.
So Sampath, are you ready?
Yes.
So why don't till he gets his network sorted out, we can start with Sampath.
Yes, sir.
Sure.
Sampath sir, you have the control.
Yeah. Are you able to see my screen now?
No, not yet.
Yeah, we can. We can.
Yeah.
Now, Sampath, you can start, I think.
Yeah. Am I audible to you all?
Yeah.
So I'm going to talk about neglected ankle fractures and basically principles. How do we treat them? In our part, it is not uncommon to get them late. So ankle fractures we see late because of some social issues, because of some economical issues, and every one of us are very well exposed to these cases. Let us go through these principles. When we are treating late presentations, we have to assess all components of malunion. We have to consider ankle biomechanics during reconstruction. We have to consider the condition of articular cartilage and also soft tissues during reconstruction. Syndesmosis, how do we reconstruct in delayed situations, we will see. And we have to treat patient and not weeks. So let us see all these through cases. Now here is a 33-year patient male who has dislocation, fracture dislocation, which is 6 weeks old. He went to a bone setter, had some massage, and this is how he was having initial X-ray looking like. Now, he did not get it treated at this stage, but after 6 weeks, he came to us like this. Now it is already organizing. We can see the good callus in the fibula, and it was with history of massage. We assessed his soft tissues; they were good. Now here we have to assess all the components. What are the components? Fibula is fractured, posterior malleolus is there, medial malleolus is there. So when the soft tissues were all right, we went ahead and planned the case. Now definitely fibula needs osteoclasis, so we need to have posterolateral approach for it. Then posterior malleolus will need mobilization, so we can access it through posterolateral approach, and medial malleolar fixation through medial exposure. This is how we did it. First mobilized the fibula, which was maluniting, then posterior malleolus. Exposure was done on medial side, and medial malleolus was also exposed, and the medial gutter was cleared. This is the post-operative X-ray, and this is how he.
Can you be a little slow? There is a little mismatch. There is a lag between your screen and your voice.
Sure.
So wait for a
I will be.
Yeah. Right, sir.
So this is the X-ray on healing, and we can see all the components have healed well. This is his function, near normal function, good dorsiflexion and plantar flexion. He is a farmer, and he is able to do all his activities, including squatting and sitting cross-legged, which is required for any Indian farmer. So a satisfactory outcome even after delayed reconstruction. So principle is identify all components of malunion and address each of them. This was the first principle. Another case is a 55-year male, and again more than 2 months old trauma. He is non-diabetic and soft tissues are good. Look at this X-ray. He is presenting after 2.5 months, and he was walking with pain. It was non-neuropathic ankle. His sensations were intact. Vascularity was good. These are his X-rays. Now we went ahead and did the fixation. Intraoperative, it looked good. Even X-rays are good. We were able to mobilize fibula, medial malleolus well. Ankle biomechanics was restored, and this is how post-operative X-rays look like. But when we did this after 2.5 months, obviously there was gain in length on lateral column. So the soft tissues, particularly fibula, soft tissues was not behaving well, and I had to use thick plate. So obviously there was soft tissue healing issue in this case, and radiologically it went on to heal well, but since soft tissue healing and irritation on lateral skin was an issue, I needed to remove the plate, and then we achieved a good ankle joint, but we had to remove the fibula plate. Ankle biomechanics were good, but then another principle, consider condition of articular cartilage. That is why we went on to do osteosynthesis, but even soft tissues need attention. Next case, he is a 23-year male. This was initial fracture, and this fracture was treated in closed manner with K wires like this. It was treated closed with K wires. Now this is as good as doing nothing in these fractures, and he reported to us almost 4 months after fixation. Now look at the biomechanics. The Shenton's line is disturbed. Every one of us, we know the Shenton's line, how to look for the ankle. It was disturbed because fibula was shorter. And this is how he presented to us 4 months later. He's a young man, around 24 years old. And we went ahead, removed the implant, did osteotomy of the fibula through fracture site, and did the reconstruction of middle malleolus. And this is how he went on to heal. And now the Shenton's arc for the ankle is reconstructed back. And this is how he went on to heal. We have got almost more than 8 years of follow-up with him. He's a young person, and look at his function, absolutely near normal function. And I will share you the video also. He keeps on coming to my clinic, and he's absolutely doing well. So this is the video of him. So consider the ankle biomechanics during reconstruction. Now this is an interesting case. She was a daily wages worker, and she had this kind of injury, again reported to us 6 weeks later. Now look at this. This is a cross disruption of ankle joint as well as syndesmosis. We reconstructed this with screws, syndesmotic screws, and this is her follow-up after almost 7 years. And look at her function. Function is good, and the way she walks is also good. Again, she is daily wages worker. She needs to do. She needs to walk on uneven surfaces. So she is doing all her activities in squatting position, sitting cross-legged.
So cancel.
I think video is, yeah. So again, lesson learned is we constructed in this case with syndesmosis, but even stabilization of syndesmosis with or inostesis of syndesmosis also recommended. I'm sharing last piece of here, female who had this kind of fracture, more than 2 months of presentation, and we went ahead here. Fibula played a key role where it was maluniting. Went ahead, opened the tibia and got it corrected. We got a good result, but here note that fibula was a hindrance. So fibula plays a different role in different cases in malunion. So we went on to heal and satisfactory as well as for correction of deformity. I will end my talk by showing this case. She got a fracture in 1968. This is the X-ray in 1988. she already got arthritis. This is X-ray in 1994. She has arthritis of ankle, subtalar, talonavicular. This is her X-ray in 1999. She's a very active woman. She has got arthritis, but she has absolutely no functional disability. This is 2011. This is the X-ray in serial X-rays 2015, 2016, and ultimately she ended up in surgery with us in 2017. So friends, we have to treat the patient, not the X-ray. Even if X-ray was not looking good, but she had no functional disability. She was very active woman. So we have to treat the patient, not only the X-ray. So I will summarize my principles, assess all the components of malunion and address them each. Consider ankle biomechanics during reconstruction. Consider the condition of articular cartilage and soft tissues during reconstruction. Syndesmotic reconstruction we may do with the screw or autograft stabilization or even synostosis of the syndesmosis, and treat the patient his functional demands and not only X-ray. Thank you, sir. Over to you, Raju, sir.
Thank you, Sampath. Malar, if you can start your presentation. Can you share your screen, Malar?
Indrajit, can you ask? Can you ask Malar to?
He's sharing. It takes a minute for his screen to come up.
Okay. Thank you. Thank you. In the meantime, sir, if you have any questions for, we can take those, sir. Dr. Rajiv Shah.
Yeah, there's a question. Role of stress views in chronic cases to identify the components of injury. Sampath, would you like to answer this question?
Yes, sir. Definitely, we should do all the means to know the components of malunion, because I agree only static X-rays or CT scan will not tell you what is exact issue. So many times on X-ray or CT scan we may see posterior malleolus which is there, but is it stable, unstable? You have to see with the stress views. So I agree. Take him not only on X-ray but even under SIAM and see with this stress.
Dr. Rajiv Shah, can I add something?
Yeah, please.
I think the stress views have got a very limited, because most of the time when the patients come to us, everything is fibrosed. Whatever you are stressing, it is very difficult to, in fact, when you are opening it, even then it is very difficult to put the components of the fracture back. So what I personally feel is that it has got a very little, maybe in a few very early cases which you get in after 2 weeks or 3 weeks, it may be some helpful, but once after 6 weeks is there, everything is consolidated. So
okay, over to you, Malar.
so any other questions, sir?
No other question.
Actually,
What is your view about the stress views, sir?
okay. Good evening. Can you hear me?
Yes, Malar, go ahead.
Go ahead, sir.
Hello.
Okay.
Hello. Yeah.
Okay.
Uh, uh, good evening. Uh, uh, Welcome to IFAS webinar. I'll be talking on the pathoanatomy of the ankle union.
We can't hear you, Malhar.
By the time Malhar gets his presentation corrected, I will start sharing my screen.
Yes, sir.
Indrajit?
Okay, sir. Yes, sir.
Sir,
You can start, sir.
Just something, because if both the video, means your own video and the PPT, it's sometimes too much of a load on the this one. So you can switch off your videos whenever you're presenting, so that becomes a little easier. Your screen can be shared. Mother, you can also do that.
Okay.
So there's one more question from Alok Jain, sir. There's one more question from my friend Alok Jain. How to assess the correction, when you're doing reconstructions?
Yeah. Sampath, would you like to answer this question? How do you assess the length and rotation of fibula when you do this surgery?
Sampath, can you hear us? Sir, if you can add to this, sir, to clarify.
So typically I paint and drape both the lower limb. That's point number one. Keep the x-rays of the opposite side on the view box, point number two. And then when you are dissecting and looking at the fibular length, you almost always require to compare the parameters of talocrural angle, sentence line, tibiofibular overlap, tibiofibular clear space, all the parameters with the opposite side and dime sign, obviously. And that is what is going to give you the correct this thing. Otherwise, there is no proper guidance that this is a very, very objective evaluation of whether you have restored length and rotation perfectly or not. One study came up and said that even in the expert hand, restoration of the length and rotation, there is error of 2 millimeter restoration, up to 2 millimeter restoration of length error is noted, and the angle correction up to 1.7 degree is noted even in the expert hand. That is what people have come up in the studies like.
Can
so
we
margin
ask
of error up to 1.3 mm in the length and 1.7 degree into rotation is what people have seen. So if there are no further questions, should I go ahead with this presentation?
Yes, sir. Please, sir.
So you are able to see my screen?
Yes, sir.
So neglected or malunited ankle fracture, they present with deformities. And these deformities can easily be corrected by peri-ankle osteotomies. So it's a great salvage option for cases where you have a focal ankle arthritis. And there are three types of deformity, and we have three types of osteotomy for the deformity. So a deformity could be at the level of fracture, which Dr. Sampath mentioned in his presentation. It could be a pure malunion, and this can be treated through osteotomizing the malunited fractures. Then comes the okay, it is not getting advanced.
Use the arrow keys.
Okay, yeah. So second type of deformity could be deformity at the joint. So if you have an intra-articular fracture, this kind of deformity, as I have drawn here with the red line, can be seen. And then for this, what you need is an intra-articular osteotomy. And there are three varieties of intra-articular osteotomy. One is plafondplasty. Another is distal tibial oblique osteotomy, which is called as DTOO, which is used for the varus intra-articular deformity. The third osteotomy is distal tibial intra-articular osteotomy, DTIO, which is being used for the valgus correction. The third type of deformity is a deformity which is above or below the joint, where you have a fracture extending into the metaphysis. And for this, you need osteotomy either above or below the joint. So this could be supramalleolar osteotomy, or even your distal tibial oblique osteotomy, distal tibial intra-articular osteotomy would also work, and you might also need to use calcaneal osteotomy or combinations. So 3 basic types of deformity and 3 basic types of osteotomy is what you need in malunited ankle cases. Talking about plefonoplasty. Plefonoplasty is the method which is in the literature being given by Professor Mark Meyerson, who said that it is indicated for intra-articular deformity, where the center of rotation and angulation is at the joint line and there is impaction of the joint surfaces, like I have shown with this figure and with this star. So when you have an intra-articular impaction of the joint surface, whatever correction you do will not last longer, because tanners would travel into that defect and they will be recreated. So how do you do plefonoplasty? These are the pictures from Meyerson's article. You put in a wire which goes right up to the level of the deformed or impacted articular surface, check into the all planes, and then put some blocking wires above the articular surface, and this blocking wire will prevent your osteotome during osteotomy to go and damage the articular surface. Thereafter, take a lamina aspirator and open this up, and look at this. It is going to bend your K wires as you open it, and then push some bone grafts into the defect and put in a plate. So this is how a plefonoplasty works. Then the next comes supramalleolar osteotomy. For a varus deformity, you could have opening medial wedge or a closing lateral wedge, plus or minus fibular osteotomy. Opening medial wedge osteotomy is more commonly used. For the valgus deformity, you have opening lateral wedge osteotomy or a closing medial wedge osteotomy. And closing medial wedge osteotomy is commonly used. So how do you do a planning for your supramalleolar osteotomy? Take a long leg APN lateral films, take hindfoot alignment views, and 2 angles are what you are obliged to calculate. Calculate tibial ankle surface angle, which is 93 degree plus or minus 4, and calculate your tibial lateral surface angle in a lateral view, which is 80 plus or minus 4, and compare it with the opposite side. Find out your scora and do osteotomy at center of rotation and angulation to avoid translation of the distal fragment. So look at this case. Male 34 had a 1-year post ankle malunion with this kind of defect into the articular cartilage, was advised ankle fusion, but by a medial close wedge supramalleolar osteotomy at the end of 1 year, this were the kind of movements this patient had. Another case, a 44 years deputy commissioner of police had an ankle malunion like this, and it was in gross valgus. This is how his pictures showed, and that's his long leg x-ray. That is the Salzman view, and a close wedge medial supramalleolar close wedge osteotomy was planned. Fibula was also lengthened, was also corrected, and this is how it went on to heal. And that's the function at the end of a year. He has gone back into the job of police, and these are his movements after correction with the supramalleolar osteotomy. Going to distal tibial oblique osteotomy, this is the osteotomy where you don't require fibular osteotomy. And this osteotomy was described by Professor Sukara of Japan. It's an oblique periarticular distal tibial osteotomy which enters into the tibiofibular joint. You need bone grafting, but you don't need fibular osteotomy. The most important feature of this DTOO osteotomy is that it can be a substitute for supramalleolar osteotomy. It can be a substitute for the plefonoplasty because it is very, very close to the joint and not into the joint. So look at this patient who had a malunion of ankle into varus like this, and then I took in, oh, there are some pictures which are okay. So there was a K-wire was passed going right up to the tibiofibular articulation, and then over this K-wire your osteotomy starts. A lamina spreader opens it up and you fix it temporarily with the K-wire, and then with the bone graft you finally fix it with the plate. This was my first case, so I was little skeptical, so I passed a trans calcaneal pin which was kept for few weeks and it was removed. This is the final function of this patient at the end of 9 months, distal tibial oblique osteotomy, and that's how he walks, and he can even jump and do all activities of routine life following a distal tibial oblique osteotomy. A distal tibial intra-articular osteotomy is an osteotomy for a valgus at the joint level, and this is described again by Professor Sukara. These are his slides. That's a fibular shaft osteotomy followed by a lateral distal intra-articular osteotomy. You have to open it and the K-wires are put as a blocking K-wire near the joint. He fixes with the plate and Ilizaro. This is his case, fibula and tibia osteotomy for a malunion which is intra-articular and leading to valgus. He corrected it. This was 1 year post-op dorsiflexion and plantoflexion. Calcaneal osteotomy has got a rare indication for ankle malunion cases, except where the cases have a very big valgus which you may not be able to correct at ankle. You might have to add a medial displacement calcaneal osteotomy. It could be a varus. For varus, you use a Dwyer's or a lateral displacement osteotomy. For valgus, you use medial displacement osteotomy. That's all. That finishes my idea, my talk onto the role of osteotomies for malunion of ankle.
Thank you very much, sir. There are a few questions which have come up, sir. Can you hear me? Yes, sir. There's one question to you from Kumar Shantanu. Is there any reliability of the dime sign?
Not really. Not really. Because dime sign is not always reliable. You have to compare it with the opposite side. So there are so many other parameters which you look when you are going for the correction of the ankle malunion. Not only
there's another question. There's another question which is from Dr. Gurunath. That is there any role of MRI in neglected cases?
That's a great question. So for me, the indications of getting MRI in a case where you have ankle malunion are 4 or 5. The first indication is when I have something looking fishy, when I feel that the things are not clear to me, I'll go ahead and get MRI. Secondly, when I'm suspecting avascular necrosis of the talus, I'll go and get an MRI. Thirdly, when there is a flak of bone over the fibular lower end of the fibula, I'm suspecting peroneal tendon injury, and it is at that juncture I would like to get MRI. And sometimes to look at the scarring and osteochondral lesions, I would get MRI. So in an ankle malunion, for me, getting MRI, these are the indications.
Okay, so can we ask foreign faculty Dr. Michael Duzella is thinking about the osteotomies in ankle malunions? Michael, can you hear us?
I'm unmuting. What was your specific question?
your experience in the osteotomies for the ankle malunions.
So Michael is going to present his US perspective as well as his case. So
Okay.
if we have some specific question, we can address to Michael.
Okay. Now there's another question to you, sir, from Indrajit. What is the basic difference between the DTOO and blepharoplasty?
Okay. So in a blepharoplasty, you don't do osteotomy of the fibula, and you are going right up to the articular surface. But in a DTIO, you do fibular osteotomy plus something like blepharoplasty. So it is addition of blepharoplasty over addition of fibular osteotomy over blepharoplasty. Now,
So there's another question from Girish, that what happens to syndesmosis in DTO when
so
you're doing.
the Professor Sukara fixes syndesmosis also. So he fixes the plate on the fibula, he fixes tibia with Elizaro or a plate plus a syndesmotic screw.
So these were the questions, sir. We can move ahead with Dr. Malar
Dr.
Dave, sir.
Abhishek, Malar, are you ready? You could start with your presentation.
Can you hear me?
Yes, go ahead, please.
Can you hear me?
Yeah,
Yes.
Okay. Good evening. Sorry for the delay due to the network issues. I'll be talking on pathoanatomy of ankle malunion. If you look at the X-ray, which is very commonly seen in our trauma day-to-day practice, and this has been another case, and this is what the trauma X-ray looks like, and then it has been fixed, which looks initially good on the initial fixation X-ray, and then 4 months down the line, what you see is some amount of translation of the talus and the shortening in the fibula, and we want to avoid all this so that we don't have to seek the help of either Sampath or Rajiv. Uh, so what is it? So what is the main thing? Main thing is to prevent the complications so that we have minimal amount of a malunion in our ankle cases, and the basic thing would be to plan for our operative fixation, and failure to plan is in these fixations leads to complications. So it should not be, oh, we have only an ankle fixation tomorrow, and it should be taken lightly by all the staff and the operating surgeon. If you look at why this is important, this was an remarkable paper by Charles Seidman from Iowa, and what they saw was the cause of the ankle arthritis. The post-traumatic was one of the most important one. It constitutes 70% of the cases. Among the post-traumatic, the rotational ankle ones had the highest constitution, was something like more than more than 50%. The other thing regarding the ankle is the ankle articular cartilage is appreciably thinner as compared to the larger joints, but still it preserves its tensile strength as compared to the hip and the knee. And there are metabolic difference from the larger joints, and therefore we can offer reconstruction and refixation till a pretty long time. According to Myers, and it's about 1 year. According to some other authors, it's up to 5 to 6 years. So you can offer reconstruction, refixation, depending upon the situation. So what are the contributors to a malunion? The contributors to a malunion would be inadequate recognition of the injury complex, the inappropriate surgical technique. You have misjudged the fracture instability and you do an inadequate fixation, or you have an inaccurate reduction in the sense that you have not achieved the proper anatomical reduction which you should have, or you have inadequate inadequately immobile fracture depending on the severity of the injury. Now, what does this all lead to? This leads to a pathological shortening. You have angulation, you have rotational problems, you have articular irregularities, as Dr. Rajiv showed. It could be a local or a global articular problem, and you can have the ligamentous issues, the instability, especially and if you are able to reconstruct and fix the symptoms, you will have good results in 75 to 85% of the cases. So how do you assess radiologically? So minimum what is required is an AP and a lateral standing X-rays. Would help you to show the translation, the arthritic changes, and the amount of fibular shortening, and this situation and the position of the syndesmosis. There was a question on the MRI, and the MRI would help you to know the health of the cartilage when you think the cartilage might not be proper, or you suspect an AVN, and you have an suspicion of a query ligamentous component. So that in that case, an MRI would be helpful. By the way, the log Hansen classification correlates very well with MRI findings. So if you have the initial trauma X-rays, the log Hansen classification would help you to estimate the amount of ligamentous injury. The position of the talus will help you to identify what amount of or what is the pattern of injury. In this schematic diagram, the medial clear space as well as the talar distance, that is normal, but there's a complete lateral translation to the lesion in the deltoid with the medial malleus and the fracture of the lateral malleus. So this would help you sort of know that the talus has shifted laterally with the fracture of the medial malleus. If you have a condition wherein there is a fracture in the posterolateral part of the tibia, posterolateral part of the tibia, then there is a lesion in the deltoid, in the lateral malleus, and in the Walkman's triangle, and that would then have a valgus sort of an position of your ankle, and this would be how the talus would be placed in that injury. When we see any posteromedial translation, that is injury having in the posteromedial complex, you have a fracture associated lateral malleus, the anterior tib fib ligament, and the fracture of the posterior malleus. The talus would be shifted posteromedially, and that would help you to know the pattern of injury which occurred. The evaluation of ankle malunion, the main complaint would be pain, and as Sampath very rightly showed, that unless the patient is symptomatic, we should not be treating just on the basis that this would lead to arthritis. So the main complaint should be pain, loss of motion, and gait issues. And you should also look at the previous heel scars so that you know how to plan your secondary procedure. You should look for Achilles tightening, have a history of smoking, because that would then tell you how the things would heal up. Take the normal inflammatory markers so that we know we are not dealing with any arthritic conditions, and the neurovascular status. The previous medical records would be very important so that you know what instruments you would need for an hardware removal in case you have to revise a surgery. So again, these are the basics: the tibiofibular overlap, the clear space, the taloreal angle, and these are the values. So we have where to measure the tibiofibular clear space, the tibiofibular overlap, and the medial clear space. These are the values which should be knowing. Uh, there was a question regarding the dime time, and there was a question regarding the dime sign, and what we have is whenever there is a fibular shortening, you will have the spike of the fibula going either to proximal, and you will have a widening of the joint space with the broken line, and that is important when you have a comparison on the opposite side. So you need to compare it on the opposite side, and then take a call regarding the values. This is an X-ray to demonstrate the medial clear space, and the second X-ray on the right demonstrate the uh, changes in the tibiofibular clear space and the tibiofibular overlap. All the ankle injuries with a fibular shortening usually have a valgus sort of an attitude, and that would be because of the intact connections between the talus and the fibula, and also because the talus is not a flat, it's an concave convex sort of an articular surface. So you have an valgus sort of a deformation usually presenting to you. The other important investigation would be would be CT scan, and that would help when there are subtle cases of fibular malrotation and syndesmotic widening, and need to compare both the sides, and also to look at the exostosis if and there in the lower end of the tibia. So CT scan would be helpful in such cases. So this is a table summarized by Mark, and this gives you all the values wherein you should consider reconstruction on the medial clear space, the talar tilt, the syndesmosis, the fibular overlap, the tibiofibular, all the values which help you to consider reconstruction. And this would help you to plan out what you need to do in your operative procedure. So sharing a couple of cases which unfortunately I was to start with, and then the other talks were there, but this was a typical ankle fracture pattern which we see in our
You
day-to-day
will have to
practice.
conclude.
And
You will have to conclude.
this was fixed. Okay, that's two slides. This was how it was fixed. With, you can see the fibular shortening. And there's another trauma. It was again misinterpreted the severity of injury, and it led to this sort of a potential complication later on. And thank you.
We have some
I think that's all.
questions before.
Thank you.
We have some questions before we go
Yes,
to Abhishek.
yes, sir.
Yeah.
Yes, sir. We
So
have a few questions coming up.
there is one
One is
question
from,
from Dr. Hitin Mathur.
yeah,
He
about,
wants to know whether you address the subtalar pathologies or not. That's a very good question, because whenever there is a varus deformity of the ankle, subtalar joint would compensately go into eversion. When there is a valgus deformity, subtalar joint would compensately go into eversion, and then there could be contracture of the ligamental structure. There could be problems of the peroneal tendon. So subtalar joint problems and the problems into the foot and ankle has to be taken into consideration, and together with the bony correction, the soft tissue correction would be equally important. Before Abhishek, you start your presentation, I am going to address one question by a delegate to you, because you are probably one of the first and one of the most dashing ankle arthroscopist of this country and future of IFAS. Role of arthroscopy in malunited ankle fracture correction.
I think it has limited role, because what happens is there's lot of scarring, which is sometimes it takes a lot of time to go in with your small shavers and debride it. It is possible. There is definitely a role. But today, with good quality MRIs and good X-rays, where you can assess the cartilage so well, and when you're already doing a complex, extremely intellectual surgery where you're correcting all the angles and everything, I would not like to waste my tourniquet time doing an arthroscopic debridement, because anyways you are going to open it if you are planning to do it. Then just it becomes more of a theoretical or more of a I know it, I do it kind of a step. But yes, in certain extra articular procedures where we are doing a supramalleolar osteotomy or with a fibular osteotomy, where I need at the same time just to debride a small osteophyte from the cartilage, I would add it. I am not averse to doing an arthroscopy in malunited fractures or neglected fractures, but I think you have to plan your surgeries. And these surgeries, both the steps are equally time consuming, like getting the osteotomy. So my to turn the statement other way around, I would say I would not waste my time doing an arthroscopy. I would rather spend time getting my osteotomies to perfection. That is the most important part. If required, you can always go in secondarily as part of your second at 6 weeks to just to clean up the joint. That patient would always be happy with doing it, I think. But more importance should be given to getting the osteotomy to precision. I think that is what is most important.
So Abhijit, if you have a posterior malleolar malunion, would you
Yes,
like
sir.
to go and do arthroscopy for those kind of cases?
Posterior malleolar means I'm just
Posterior
correcting
malleolar malunion,
isolated posterior malleolus malunion. Will that be correct, sir?
or any malunion where there is an element of malunion of posterior malleolus, because that
Okay,
is the indication described presently in the literature for doing
correct.
arthroscopy.
So posterior malleolus, I think the advantage of addressing posterior malleolus arthroscopically is it gives you a kind of entire horizon view. What do I mean by horizon? Means you can see posteromedially as well as posterolaterally. So by that, why they say you can address, and it's quite easy to go in posteriorly. I do go in posterior malleolus. Even lot of my posterior malleolar fixations, I would do arthroscopic fixation for posterior malleolus, because it's quite easy. I can pass my percute fixations medial as well as lateral without really being troubled about the neurovascular bundle. Yes, posterior malleolar malunited component, where I am sure the posterior malunited component is causing symptoms to the patient. As Sampath sir said, it is symptomatic. Yes, I would address it arthroscopically.
Thank you, and go ahead with your presentation.
Okay,
You have
my
5 minutes.
yeah, slides are visible, sir.
Yes. So there
Okay.
was one more question to Dr. Rajiv sir. After
Please.
osteotomy, what is the weight bearing protocol for these after osteotomies?
So these patients are given a splintage for about 4 weeks, and then they start non-weight bearing mobilization. Weight bearing is never started before 8 to 10 weeks. So by 8 to 10 weeks, a progressive tolerable weight bearing is started, and they go back to activities by 3 to 4 months. Abhishek.
Thank you, sir.
Okay, sir. Is my screen visible, sir? Voice audible?
Yes,
Absolutely
everything.
Okay.
fine.
Okay, great.
Loud and clear.
So, hi, I'm Abhishek Kini. I'll be talking on the role of arthrodesis in this. So, as we've seen that, okay, as we know, this is the beast that we are discussing right now. It's a malunited, neglected ankle. And Mallar sir showed us what is the anatomy. Sampath sir showed us how you can reconstruct these fractures when they come too early. And Rajiv sir also showed us how you can still salvage it by preserving the joint, like doing a joint preserving osteotomy. But more often than not, when patient comes to us is with arthritis. I know a lot of people would still try and conserve it, but also cartilage is safe. So when you feel that you can't do a good job and you still feel that the patient at the end of your procedure can still have pain, what further option is remaining is a good arthrodesis, which is like the gold standard when done properly in indicated patients. So what are the objectives? What are the objectives of restoring is to restore normal lower limb alignment biomechanics and to achieve stable painless foot for locomotion. And what are the considerations while doing the arthrodesis in an ankle is like we know that up to 26% of dorsiflexion plantarflexion is possible at intertarsal joint. That's been shown by Astion et al. In JBJS. So the key is to do a selective fusion, and very important is to do a realistic evaluation of patient's expectation for treatment. When the patient comes to you for a painless walk, you have to counsel him that this is one of the options where you can get a painless walk for a good functional outcome. Our country is a lot of diversity, state. I just got a message that my screen is not visible.
No, it is.
Hello?
Abhishek, we can clearly see your screen.
It is visible. It is visible.
Screen is not moving.
Am I audible, sir?
Yes.
Yeah.
Yes, Abhishek.
Abhishek, you're
Moving. No worries.
it's fine.
In our country, there is a lot
Everything
of
is fine,
diversity. Like there is city and urban life villages, there are local trains, crowded transport, we have tall rises as well as hutments. On the contrary, the challenges of these patients are they are part of a complex injury of polytrauma where ankle is neglected. Sometimes they are open injuries which can bring about infection and late presentations and inappropriately treated conditions. Add to that the demand that a country asks for is like squatting, field work, and an urban lifestyle which is like full of crowd. So keeping these socioeconomic considerations, when you examine the patient, you have to examine or you have to listen to the history, whether it was open, mark the surgical scars, note what implants were put into them. What high energy or open fractures, look for surgical scars, implants, and also check for associated neurovascular injuries. Look for quality of soft tissue envelope where there is a local flap done or something. Along with this history, what is most important is an astute evaluation of deformity and arthritis. That what do I mean by deformity and arthritis? Like patients can come with varus deformity or valgus deformity. They can be compensatory internal external rotations to the deformity. You also need to kind of evaluate which joint is affected. Like along with the ankle, as Dr. Hiten just suggested, is there a subtalar involvement or talonavicular involvement also, or is there a mid-tarsal involvement also? These associated joints which are involved play a big role in your functional outcome, because for a patient, the pain is a pain, whether it comes from an ankle or whether it comes from a subtalar region. So it's very important that you kind of examine them properly. In a radiological examination, what you need is a good standing x-rays, check them like properly, do a CT scan on an MRI where you'll find out the other joints are normal. If in doubt, do a technetium bone scan or a SPECT CT where you can find out which is a hotspot, which joint is throwing or taking up more uptake. Sometimes to differentiate which is the contributor, you can do a differential anesthetic blocks and injection. Like for example, in this patient where ankle and subtalar both were suspected, we injected the subtalar joint, confirming, and the patient signs and symptoms did not improve much, saying that the ankle was the main contributor. Now after this, once we have done with the pre-op evaluation, you know where the deformity is and what joints are arthritic. What you need to do is plan your arthrodesis correctly. Plan is to approach. My workhorse approach nowadays for the last few years has all been lateral. Like I approach my ankle fractures also laterally, even pylons I am approaching laterally, as once I've discussed with Dr. Rajiv sir. Anteromedial, posteromedial, sometimes you may have to go posterior. That's another excellent approach. If you master it, it's going to be a saving option for you in most of the things. I plan and do most often than not a closing wedge kind of a procedure where I bring my articular surface or bring my raw surfaces approximated where I get good fixation, and I try and bring about compression in most places. So fusion, once achieved, gives high degree of satisfaction and pain relief and restores function. But the fundamental principles are good soft tissue preservation, adequate surface preparation, compression at the site, and a good rigid fixation. So how it can be done? Yes, possible arthroscopic, but yes, difficult, challenging, but yes, we do up to around 10-15 degrees of coronal plane deformities with arthroscopy. More often than not, in my hands, I do it open with internal fixation, more often with screws than with a nail, and rarely in our country, but yes, in infected cases, I do put an external fixator like a Chandi's compression clamps. So my position is supine, ipsilateral, hip elevated, heel on the edge, where I can take an axial view with a C-arm. I do a transfibular approach, single layer up to the fibula. I osteotomize the fibula and I use it as a bone graft, especially in my valgus cases. Ankle joint debrided up to bony resection, approximate raw bones, and then get medial malleolar osteotomy if required. So approximate raw bone to bone and medial malleolar osteotomy SOS if required, and I fix it with a transarticular screws. So if you've kind of done your examination properly, got the deformity addressed, arthritis, and addressed the proper joint following the principles of surgery, I think ankle arthrodesis gives extremely good outcome, and patients are extremely happy doing all the hard work that our country demands from them to do it. So to summarize, I think our country has diverse lifestyle and demands. The late presentation, post-traumatic, post-infective with arthritis, more often than not end up with a fusion as it becomes one terminal surgery for them. I prefer doing them with open with internal fixators, sometimes with external fixators and arthroscopy assisted. What is most important is to understand the biomechanics of the ankle and foot, astute examination to check where the deformity is and what joints are arthritic, and follow the principles of fusion, and you will have a good result. Thank you, sir.
Abhishek, before you leave, there is a question from Abhishek Jain to Abhishek Kini that in most of his ankle fusion, whatever he has done in neutral position to 5 degree of dorsiflexion, the midfoot goes into equinus. Is it normal? If not, how to prevent it? And what is your experience regarding it and that of the other faculties?
Sir, excuse me, Dr. Rajiv Shah. Dr. Allen has to go and see his patients, and he wants to finish his talk.
Yeah.
So can we invite Dr.
Yeah,
Allen?
Sure.
Dr. Allen, please.
Yes. Hi.
You're welcome. Hi.
Good morning. And this is my morning, probably. I apologize. I'm mixed up with the time, and this is my clinic. But anyway, so it's a great chance to talk to my colleagues, and thanks very much for inviting me. So my talk will be how to making some rational choices in ankle fracture in those difficulty cases in the delayed and difficult situations. So compared to India, it's probably our malunion delayed cases are rare. But anyway, if that happens, and there are usually some special situations and make those ankle fractures difficult. So let's just give you my perspective and start with a couple of cases that in my practice I have to try to illustrate the situation here. Let me make it okay. All right, and you can see my screens, right?
Yep.
Okay. So this is my disclosure. This is my disclosure, and my talk. There is no conflict. So the first case I would like to present is this is my record of how old the patient that I have treated. So this lady is 105 years old, and so she's got a low energy fall. It's probably a syncope fall, and she is demented with hypertension, chronic renal disease, CHF. She is not diabetic. And due to her age and dementia, and usually that scare off many others due to that age. And this is one of the conditions why some of those patients getting neglected because people are trying to treat it without surgery. So this is the the time when I see her, and she has a medial malleolus ulceration, which is due to the malreduction or inadequate reductions of the medial malleolus. It's still subluxed and dislocated. It's about over 1 month. It's probably at 5 weeks post the injury, and she was just to put her into a boot. So in an elderly patient, this is a unique situation. Is they pretty much, if you order them to be partial weight bearing on non-weight bearing, that's probably it's much more dangerous for those cohort of the patient if they cannot moving around, and that's probably they could die from it. And this is the original X-ray of that patient, even if it's a low energy injury, but it's completely dislocated and with a fracture. So, and this is the time when I see her, and this is the amount reduced, and it's been like 4 or 5 weeks, and I'm not so sure whether a acute reduction could achieve what we are going to do, and it's already proven to be trouble, and she already has a medial ulceration. If it's left neglected, probably the next thing will be an infection, and in her age, with her physiology and multiple medical complications, she probably ended up losing her foot, or then cannot survive. So with all those situations, so considering the facts and our limited choices, so if she is sent it over to a foot and ankle specialist, probably the other general orthopedic surgeon is kind of a little bit scared off those situations. So what the option in my hand? So I have to consider the physiology and her situation. We're trying to do minimal invasive. Elderly has a poor envelope, poor wound healing potentials. The soft tissue envelope, once you do a regular kind of incision, it will get into complication easily. So in my talk, I would like to introduce a couple of points that I available here. So what I did is a gradual correction with Elizarov, and this is my choice, and it's probably lucky. So with other situations with a chronic condition, they have scarring tissues. Not quite often those tissues like other joints that we could have like an hourglass kind of a contractor in the ankle. To my limited humble opinion, they do not have that quite often, but could be have a scarring tissues prevent you, or the soft callus prevent you from correcting. So always bearing in mind you need to use a limited incision to do osteotomy if you need it. But she's quite lucky that I can correct it pretty much closer to a preferred reduction. Still have a varus alignment, and this is I put it into a Elizarov and planning for a gradual correction. However, she cannot tolerate it, and she is a 105-year-old. But anyway, I'm pretty satisfied with that position, and she has been able to maintain it for about 3 months. And 3 months we take it off, everything is stable. And the other advantage that I use this is I can directly address the wound and with a wound care nursing visit to the patient's home and taking care of that. That wound healing is really good. Now that patient with the frame, she is able to tolerate the weight bearing immediately. So there is other options that I would mention, but I didn't expand on it. There is a trend that with that kind of fracture in the elderly ankle fracture, there is a trend that we're doing TTC now primarily instead of doing ORIF. And limited data shows a good outcome so far. But my concern is with large nail, with a stress riser, and also with a reaming into the medullary canals into the compromised physiology. So cardiac pulmonary consideration is one of my concerns. So compared to those two options, I choose this one, and this is successful in this patient. Now, the other case that I have is intentionally neglect. So it's kind of similar situations here in the West. So this is a 72-year-old male with a syncope fell and twisted right ankle on ice, admitted and consulted the orthopedic service, and he has uncontrolled diabetes on insulin. So the HbA1c was 11, and also this guy has multiple issues with coronary artery disease, triple bypass, AFib, obstructive sleep apnea, chronic kidney disease, COPD, and MRSA infection history before. So this is the film. The film doesn't look that kind of treacherous. You know, so you look at the kind of a subluxus mortis is out and fibula is short and with a minimal off and in a valgus position. So it's an unstable bimal fractures. It could be a trimal. So as the other surgeon has already mentioned, the advanced imaging role in those type of patient is important. And my finding is probably dynamic imaging is not that much of importance in those cases, but CT scan is quite critical in those situations. Now, this is the bilateral lower extremity appearance with chronic venous stasis at baseline and minimal sensations, which indicating he has peripheral nerve disease. And in those patients, even if they do not have a Charcot, in a lot of situations, this is set off a Charcot situation. So the choices are those, whether you're going to do it a non-op with a cast. If you have been doing foot ankle for a while, so this is against our principle. So, but in the hands of general orthopedic surgeons, probably some may still consider. So the ORF with regular incision, regular implants is the same issues for those patients. It's risky, and their envelope with the glycosylation of all the tissues and their healing potential, the immunodeficiency or immunocompromise the situation, so they do not do well. The complication rate is really high, and the other general principle right now is mostly we follow with bigger incisions, double implants, double the time of immobilization of those patients, and multiple screws from the fibula to tibia. So the other option is, how about MIS? MIS was ORF with incisions much smaller and with a biological augmentation. Sometimes it was arthroscopic aided to get an anatomical reduction. So this is what I did. In the beginning, this is early in my practice, so I tried to reduce it again and tried it with serial casting and tried to do it each week follow up. However, that does not work, and I already see the compression ulcers earlier, so that sets up amputation in the next, or you need a fusion. But anyway, so the decision is made to a MIS, and I fixed it with a fibular rod. And there are some technicalities of using fixable rod, but fibular rod has served me really well for that type of patient. And so far, I have not got much of a complication. And this is how small the incisions are required. And we're using ligament tactus. And sometimes you prepare for arthroscopic assisted reduction and prepare for biological augmentation in those patients. So non-operative is not universally not doing better, and higher malunion rate, higher infection rate, and higher amputation rate. So the diabetic patient with peripheral vascular, peripheral neuropathy, so there are increased risk for complications regardless of what type of treatment you have. So this is the MIS incisions, and I have not had any major wound complications since I used this. And the biomechanically, the implant is doing pretty well either. So neglected ankle fracture in the US, again, it's very rare. And also there's a paucity of literature because of that. And however, when it happens, it's really and bad. And major issues. Those patients probably have extensive scar blocking your reduction. So be prepared for arthropathy and osteotomy. So in the medial side, you cannot, if you cannot achieve that, sometimes medial osteotomy with scarring clearing, it's necessary. Contraction of the soft tissue, prolonged subluxation, dislocation, or a malunion of any lateral mal, medial mal, posterior mal, you're prepared for osteotomy to restore the anatomical structures to buttressing the talus and ankle relationship. And usually you combine with complicated healthcare issues. A lot of people with chronic diseases and the psychological issues or other personal social conditions. In the US, there's a special group of patients or inmate or a psychiatric patient that could happen to them in that situations. And the lower socioeconomic conditions is usually quite common among those type of patients. And you need to rule out infection before you make any further decisions. Whether you do a fusion kind of a surgery, correctional kind of surgery, depending on the age, depending on their joint condition, full length bilateral comparison of their alignment need to be considered. The principle will be the same. If they have any suspicion of the infections, I would never using a total ankle. And also, I prefer using a total ankle in the patients over 55 years old as a principle. So the other thing is, you may not be able to preserve the joint. So TTC now is either using acutely or chronically to solve the problem. So main aim to achieve is a best scenario anatomical reduction and preserve the joint. And a lot of those patients are young, so you could do a takedown in the future for total joints. Conventional approaches sometimes does not work. You need extensive dissection if the patient has avascular necrosis concerns, and you need osteotomy. Wound healing is an issue, and it's not predictable results in inevitably bad outcomes it could have. So limited open MIS approaches is a good option, and gradual reduction of chronic fractures dislocation using a Lazaroff or a TSF is a good choice in those patients who has the soft tissue envelopal concerns, infection situations, and with a chronic contracture of the soft tissues. So gradual contraction use the Lazaroff technique, a staged ORF combination, or using frame as a definitive management, or using the frame as a fusion as possible. So joint sacrificing procedures may apply, and sometimes you may do it acutely, depending on your situation. So, so we're all in this pandemic situation, and the whole world doesn't worry about India, and we're into this for a while. So, but I'm back in my office and seeing my patients, and hopefully we can start our selective surgery pretty soon. Thank you very much for the invitation, and I give the floor to Mike.
Alan, we have a few questions which
Yes.
we are there. One is that what happens to the stability once the Lazaroff frame is removed? You know, you're not getting fusion; you're just putting them back.
Yes. So that's quite special in that case. It's a 105-year-old. So the range of motion stability is, stability is more of my concern. The range of motion is she's gonna getting stiff, but that's okay for her. If she can use it as a baseline, she's probably just walking inside the house. And she ended up doing pretty well. So in that situation, I wanted to do too much of reconstruction works, as the other surgeon has mentioned. If somebody has a syndesmosis instability, and sometimes they have synostosis also. So that requires a lot of reconstruction, and sometimes using allograft to replace the ligament and with the hardware enforcement. So if that answered the question.
Dr. Rajiv Shah. So Dr. Rajiv Shah, can you hear me? Dr. Rajiv Shah, can you hear me? Dr. Rajiv Shah?
Christy, can you check that patient?
Dr. Rajiv Shah, can you hear me? Indrajit?
Wait a second, I'm looking.
Dr. Rajiv Shah, can you hear me? So I don't know whether Dr. Rajiv Shah can hear me or not, but there are a few more questions to Dr. Allen. Can we go ahead, Dr. Rajiv Shah, will you? Okay, sir, there is one question that in the second case, is there any role of primary arthrodesis in that diabetic ankle?
In diabetic ankle, primary arthrodesis in diabetic conditions, if you rule out infection, if there is infection, probably I would prefer using a Lizaroff and using a Lizaroff fusion. And primary fusion, it is a possible choices. Yes.
And there's one fellow who wants to know something about the fibular nail. Dr. Rajiv Shah, can you hear me? I can't. But there's one question on fibular nailing. Actually, what are your indications for that?
Indication for fibular nail. Right now, my indication is diabetic fracture and also geriatric fracture. Because the geriatric fracture is if you have operated on a couple of those, at least to me, because of severe osteoporosis, you have to use a locking plate, and sometimes with a locking plate is still, and you need to put like more than one plate. So the ligament tactus, without open up the whole thing, works pretty well in my hand. So fibular nail has served a good option, alternative to the traditional way of fixating the pivotal fracture. But the caveat is, so it is an IM nail, so you have to achieve the reduction before you put in the implants. Otherwise, the nail will not help you to reduce it.
Dr. Rajiv Shah, can you hear me?
No, I am able to, but you people are not able to listen to me.
Yeah, I cannot. We cannot hear. And now I'm hearing you. And that's why I was going on. Can you now take the charge, please? I think there's some problem with Dr. Dr. Indrajit.
So please start with Dr. Michael.
Thank you, Alan. If you can see a few more patients and join us once you're free. Thank you very much. And in the meantime, I request Dr. Duzela to start us talk on the total ankle arthroplasty in these difficult situations.
Thank you. My pleasure to be here. Dr. Rajiv Vora, thank you for the invitation. My dear friend, Dr. Rajiv Shah. Can you guys see my slides?
Sure, sir. Sure, sir. We can see your slides.
Excellent. So today we're going to talk about total ankle replacement in the setting of malunited ankle fractures. And as Dr. Shah said, patients with good subtalar motion, interestingly, they can very much accommodate for significant angular deformities. And so I think it's very important, especially when we have these chronic deformities, that we try to obtain contralateral films. As Dr. Shah said, we want to particularly evaluate the medial malleolar osteotomy or malunions, which can be somewhat difficult to ascertain without comparative films. And sometimes these medial malleolar malunions can be very difficult and predict poor outcomes if we're not able to adequately reduce the talus. And so what's interesting, I think, in a lot of these patients is that arthritic changes themselves, they don't always influence the clinical outcome. I think as long as the hindfoot is perfectly aligned. And I had a very kind opportunity to work with Dr. Beat Hinterman, Professor Hinterman, as an AO fellow in Switzerland. And Many of you who know Professor Hinterman, everything he does is based around perfect hindfoot alignment. And with total ankle replacement, I think that's very important. I think the key here is we're unloading these areas of degenerative cartilage with the idea of extending the functional capacity here by sort of unloading these areas and then loading an area of intact cartilage instead. One of the challenges I think that we run into, though, is particularly with these malunited fractures, is that we can develop significant chronic hindfoot malalignment as well. So not just the ankle, but we'll see a subsequent compensatory hindfoot valgus, and oftentimes the forefoot goes into fairly severe abduction as well. As we talk about this, Dr. Keeney gave a very nice discussion on fusion, and I am certainly a proponent of fusion. I think fusion is a wonderful operation, provided that the patients have no adjacent joint arthritis. And if you have a patient with significant valgus deformity, particularly when there is deltoid insufficiency, unless you're very adept at total ankle replacement, I would encourage you to probably consider fusion. Again, as long as those adjacent joints are in good health. Dr. Yan mentioned conversion of total ankle or conversion of fusion to total ankle replacement, and I will show a case with that. So let's go ahead and go through this. These are my disclosures. If I can make this advance. Is there an arrow key somebody mentioned? I guess this is it. Okay. These are my disclosures. There's nothing relevant to my discussion today. So is ankle arthroplasty a viable option? Absolutely. There's a broad range of deformities where we can use this technology, but the key again is realignment.
There's a little lag with you. So
okay.
You go a little slow slide in your voice. There's a little lag going on there. So we are on the introduction slide now.
Okay, you want me to speak slower or move the screen slower?
Yeah, just go with the screen slowly.
Okay. So introduction, when we're talking about deformities, oftentimes we're talking about deformities in the coronal plane. And I think this is the most important factor when we're talking about total ankle replacement, particularly with residual angular deformities. And with instability, one of the issues we can run into here is edge loading of the polyethylene and essentially a subluxation of the bearing. And with this, we can see a failure. So we want to be careful that we have good realignment. If we look at some of the past literature, I think we've seen some fairly unsatisfactory results in multiple publications here associated with coronal plane deformities. And that's led us to recommend, particularly in those who are not doing a lot of total ankle replacement, to keep the coronal plane deformities fairly minimal. So in other words, 10 to 15 degrees tends to be the area where we start to get into a relative, if not absolute, contraindication for less experienced surgeons. So additional procedures, I think this is one of the things we've talked about, osteotomies. You've had some beautiful talks on supramalleolar or fibular osteotomies, but also making sure that we have ligament balancing, and particularly the primary mode of failure when we see preoperative deformities greater than 20 degrees, if they're not significant bony malalignment, is instability. So if we have a deltoid contracture or posterior tibialis fracture, we may need to address that, as well as considering lateral procedures such as a perineal longus to brevis transfer, maybe a lateral ankle stabilization, and then also looking at the hindfoot malalignment. So this is important when we're doing our Saltzman views to check for the hindfoot malalignment to determine whether calcaneal osteotomy is needed, and also even potentially a dorsiflexion osteotomy of the first metatarsal. So as we're moving on here, we're discussing ligament instability, assessing the deltoid, and this is a strong consideration for fusion again. And in some cases, we have a very subtle syndesmotic disruption, has been previously discussed today. But also, it's important to assess that syndesmosis, maybe even stressing it. And you can see in this particular case, a very glaring latent syndesmosis injury. So is deltoid reconstruction feasible? Well, certainly multiple publications exist. Mark Myers, Steve Haddad, multiple people have talked about this, but in reality, it can be very difficult. Allografts often fail and stretch out. We're working with arthroscopic techniques now, doing all inside using suture tape augmentation, but again, very challenging, particularly in the setting of wanting to do a total ankle replacement. So can we do total ankle replacement in association with hindfoot fusions and osteotomies? Well, I was with Professor Hinterman, he was completing this work, and subsequently my co-fellow Bamsu Kim published with him in the Journal of Bone and Joint Surgery. And what he showed was that it was a very feasible option to combine simultaneous subtalar or triple fusion. And the reality is the outcomes were quite good. And he felt that they should be performed in unison. Here in the US, I would say that this is a less common approach. We tend to stage these more often than not. And here's an example where we've done a total ankle replacement and a subtalar fusion. Let's see, someone's asking for my camera here. Can you see me? Where we've seen a subtalar fusion simultaneously done, and you can see through this single anterior approach, going through the talonavicular joint deep into the posterior subtalar joint to clear that out in preparation for a fusion. So malalignment, again, coronal plane deformities. This may be addressed with a tibial osteotomy, a supramalleolar osteotomy. I did a fellowship with Thomas Lee and Greg Burlett at Orthopedic Foot and Ankle Center in Columbus, and they were always very imperative that we overcorrected by several degrees when we did a supramalleolar osteotomy to account for any settling. So typically 3 to 5 degrees we will overcorrect. So again, calcaneal osteotomy, subtalar joint fusions, triple arthrodeses. And so again, residual angular deformity in malalignment can result in significant wear of the polyethylene, and you can see progressive edge loading and early failure. So this is the algorithm we use. We're looking at the implant insertion and checking, is there any residual heel varus? If there is residual heel varus, then a lateralizing or valganization calcaneal osteotomy via Dwyer procedure is performed. And in that case, we're also assessing whether there is any forefoot-driven components where there may be a plantar flexed first ray. And we're doing a dorsiflexion osteotomy of the first metatarsal as necessary. So looking at incongruent varus angle, you can see my slides are lagging a little bit here. You can see this area here where we have a incongruent varus, and we clearly have significant lateral ankle instability present with ligamentous laxity, and this is not due to a malunited fracture. And you can see the tremendous deformities. So this is an example with often perineal weakness, chronic repetitive lateral ankle sprains. So when we have a moderate to severe varus ankle with an incongruent varus deformity, our algorithm includes a medial release, including the deltoid by a deltoid peel, sometimes a posterior tibialis tendon lengthening or recession, along with residual a check that there's any lateral opening. If there is any lateral opening still, we're making sure that we address that through a modified Brostrom procedure. And then also checking that there is good ligamentous balance to make sure that we're not going to see any edge loading. So for angular deformities, again, it's important that we have excellent realignment. And you can see here an example where both a fibular osteotomy was created as well as a tibial osteotomy, and we'll go through some examples in a moment. The question is, will this prevent edge loading, and does this prolong the life of the implant? So here's an example of the congruent varus deformity. And we're addressing again with a medial release and a neutralizing tibial cut in the congruent varus deformity. And then again, checking if there's any lateral instability that needs to be addressed with the lateral ankle stabilization. Forgive me, there's about a 10-second lag on my slides here. So this is an example of a tibial and fibular, or fibular malunion and a tibial osteotomy for a old bimalleolar fracture, showing fairly nice realignment here. And in extreme cases, this is a case that I did, you'll see in a moment here with Professor Hinterman, where it was an extreme deformity associated with the malunited fibular fracture over the years, where this has gone into a very subtle incongruent varus deformity of about 45 degrees. And this was corrected with both a tibial and fibular osteotomy. So that's in preparation for a total ankle. So in angular deformity cases, I think a lot of times we'll see a scenario like this, where we have a incongruent varus deformity with clear lateral ankle instability. And we can correct these through a supramalleolar osteotomy and lateral ankle stabilization. In this particular case, this was not corrected with lateral ankle stabilization, merely with a supramalleolar osteotomy. And you can see what happens when you don't address the ligamentous component, where you have a residual varus deformity present. In the US, we have a total ankle system available from the Zimmer company that allows a lateral transfibular approach, which is quite an interesting approach for a patient who has a malunited fibula. In the absence of a malunited fibula and a primary total ankle arthroplasty, I think it would be difficult to recommend a fibular osteotomy for the purpose of doing this procedure. Again, with Professor Hinterman, the opportunity to do some fairly extreme corrections here. As you can see, with a cora, as Dr. Shah mentioned, above the level of the ankle, these can be somewhat complex to correct. So this was managed with a tibial supramalleolar closing medial wedge osteotomy, a fibular osteotomy, as well as a lengthening medial malleolar osteotomy. And that lengthening medial malleolar osteotomy can be done in some patients when we have insufficient correction with a deltoid peel. Here's an example of a recurvatum deformity that was addressed. Let me back up just for a second here. You can see this is a recurvatum deformity after a pilon fracture, high energy motor vehicle accident. This was a very poor outcome for this patient years ago. So this was addressed through a posterior medial osteotomy with a posterior closing wedge. And you can see with a compression device how we're able to get that to close. And AP view along with the fibular osteotomy, we can see some nice realignment here. And this is a posterior medial approach, which you'll see in just a moment here. And here's the closing wedge with application of a plate and a compression device to get that to close. And obviously these can be quite stiff. So the question is, can total ankle replacement be successful after a malunited ankle fracture? And the answer is absolutely. With a broad range of deformities, we can address for a total ankle with both supramalleolar osteotomies, fibular osteotomies. But again, it's important to recognize the role of ancillary procedures such as calcaneal osteotomies, possibly adjacent joint fusions, and then also considering ankle arthrodesis in our patients who have severe deltoid insufficiency. So I'm just going to roll into some cases quite quickly here. Sorry, there's a significant delay on this screen. I really apologize. So varus deformity after total ankle replacement. This is a case from Professor Hinterman, just to show the very subtle things that we can accomplish with total ankle replacement and with malalignment. So this is a case where we have a very subtle varus deformity. There's some sclerosis medially with stress shielding. We have this subtle varus deformity with a lateral. This was addressed with a lateral tibial closing wedge osteotomy also with medial translation due to lateral impingement. And this is basically how this was done. It was addressed through a fibular osteotomy, fibular cut. And we can see here how that's accomplished. Catch up here. And then there's a lateral closing wedge osteotomy performed just anterior to the fibula. And these are the guide wires that we'll use for the performance of the osteotomy, and we can check that fluoroscopically. And with the completion of the osteotomy, this is the result that we see here. And so here is the application of the locking plate. And if we can see here, the fluoroscopic imaging showing the fibular osteotomy, that distal tibial segment is medially translated as well. So that was a complete osteotomy, and then application of an additional medial plate. And this is the final radiographic fluoroscopic appearance, which you can see quite a nice realignment with the combination thereof. So this is the final case I wanted to show you. Is quite an interesting case. This is a takedown of a total ankle replacement. This is a gentleman who who had a previous ankle fusion performed because of a motor vehicle accident. He had a severe varus deformity, and he subsequently developed subtalar arthritis and some talonavicular discomfort. He was not happy with having his ankle fused. He was 42 years of age and requested takedown. So this was approached through a lateral approach, and one of the interesting things about this is that this gentleman had no fibula. This was done through a transfibular approach. So a subtalar joint fusion was performed through a lateral approach, and then approaching the anterior aspect of the joint, the talonavicular joint was cleaned up. Total ankle was taken down. So basically, you're using your anterior jig here, and then an osteotomy is performed. Let these slides catch up. So you can see as the osteotomy is performed through the previous fusion site, and about 8 millimeters of bone is removed. You can see if that segment of bone is removed, where the joint is recreated here. And then again, the subtalar joint is fused. And we can see the preparation for the total ankle replacement. We can see here with the fibula now being mobilized, because we have to have fibular stability for a total ankle replacement. The fibula is then translated distally and prepared on the back table. Fenestrated, and then used as an onlay graft and fixated. And soft tissue repairs are performed. And that's a fusion onlay attempt of the fibula. And studies show we need about 8 centimeters of fibula for a stable outcome. So you can see the lateral view of what that total ankle replacement looks like, the subtalar fusion. And here's the important picture next, as we can see with that fibular onlay graft for a fusion and distal stability. So the alignment looked quite good. And this is a little video, hopefully that'll show in a second to see the range of motion. On the screen, you can see a little bit there in slow motion, but nevertheless, it seemed to work quite reasonably. And that's my talk.
Thank you, Michael. It was really a wonderful talk. You have shown
with such a slow, very difficult to keep up with the slides. There is a very significant delay. I hope
it's a wonderful talk. How the reconstructions you've been doing amazingly well, reconstructions with the total ankle in these malunited ankles. There's one question for you. I don't know. There's one guy who wants, my friend Lok, he wants to ask, is there any incidence of neuroarthropathy after TAR? So probably wants to ask, do you do these procedures in diabetics also or not?
So that's a great question. I think that a diabetic is a candidate, but not with any degree of neuropathy whatsoever. So our absolute contraindications would be advanced neuropathy or dense neuropathy, and then also infection, as Dr. Yan mentioned. And then in the US, we have a lot of overweight people, so high BMI is also a contraindication. So the ideal patient for total ankle replacement would be 55 or older, low activity level, low BMI, and healthy without comorbidities. And the reality is, studies show these have a viability of about 10 years, and there's high degree of revisions necessary. These aren't patients that you can say goodbye to and see them in 10 years for their revision. You'll see them fairly frequently. In some cases, revisions are necessary. Debridements, arthroscopic debridements, sometimes a poly exchange, sometimes a late infection. So there is no doubt in my mind that a fusion is a much easier operation, technically as well as in terms of postoperative management. But again, we have the adjacent joint arthritis issues to contend with.
So have you found any difference in outcomes as compared to the normal arthroplasties when it is done for other ankle arthritis or rheumatoid or anything like that? And when you do it for neglected ankle fractures, the incidence of complications, your follow-up, what is the difference in the outcomes in these?
Yeah, certainly the patients with comorbidities, particularly those who might be on disease-modifying agents or immunosuppressive agents. Here in the U.S., many patients are receiving things like Humira, infliximab, Remicade, these types of medications. That anterior wound, that angiosome, is very complex, and when you see a failure of that wound, you can be in some very difficult trouble. Oftentimes needs a free flap, actually. So you have to have a very good relationship with a plastic surgeon once you start embarking on total ankle replacement surgeries, because once in a while you definitely will see these wounds fall apart, and they can end up not short of losing a limb. So we certainly have seen some patients lose legs over the years with this procedure. So obviously the patients with rheumatoid arthritis and comorbidities are at higher risk for wound healing issues. But with the bony component, I think you just have to be very careful that you have good bony structure and good support and not significant osteoporosis as you embark on these.
I'm a little worried. The case you showed when you had a lateral incision as well as the interior incision, the two incisions, and then putting it so much implant into it.
Yeah.
How did that case do? It went well?
Yeah, the wounds look fine. There was no wound issues with that one, but you're certainly correct. You know, as we have a limited island around the anterior aspect of the ankle and lateral ankle, that can run into some trouble there. Indeed.
I hope Dr. Rajiv Shah, you are here with us.
Yes, are you able to listen to me?
Yeah. You can now carry on. You can please carry on, please.
Thank you, Michael. Thank you for your time and thank you for accepting our invitation.
Thank you. It's a pleasure to be here. I learned a lot today. Thank you.
Yeah, and be with us while we go ahead with the case presentations. Right?
For sure.
Okay. So, Abhijit, start with your case.
Yes, sir. Thank you. Good evening, everyone, and also it is a great initiative of IFAS. So I just go through quick with my case. Can you see my skin?
Yes. Go ahead.
So not.
Dr. Rajiv Shah, there's one question from Hiten, if you can ask in the meantime.
Yeah. What is that question? Let me just see.
Have you seen?
I'm just looking. Yeah. Michael, there's a question for you. Are your results of TAR better if there is mild residual varus or there is a mild residual valgus?
No doubt, Vera seems to do a little bit better. The valgus failure is dismal. When we see that, particularly in that in the talar component, where we see these fail most often is in the talar side. You see subsidence of the talar component. Really, I'm not sure you can say that any degree of coronal plane is acceptable. They really have to. I can't emphasize that enough. They have to be perfectly balanced. But valgus is a dismal outcome.
Yeah, there is one more question from Dr. Rajesh Shaiman, and he has also conveyed regards to you that how often you have deferred total ankle replacement after correcting the malalignment.
I'm sorry, I didn't understand the question.
So he says that how many times you have deferred total ankle replacement after correcting the malalignment.
This is a good question. Yeah. So again, we're not treating x-rays. I think we're addressing function. If the patient doesn't have pain and we've realigned the ankle and we have better loading of the residual intact cartilage, some of these patients are now asymptomatic or minimally symptomatic. And I don't think it makes sense to go for a total ankle in those cases. It's purely reserved for patients who have failed reconstruction. And there are certainly cases that occur like that. I will tell you that in my travels and doing training in Switzerland and Germany and working with you in India as well as in China, that American patients tend to be very feeble. and that they complain a lot, and they have pain a lot, much more so than we see in other countries. And so I would say that it's the exception rather than the rule that we do a malalignment correction and they're fine afterwards. Certainly symptoms improve, but they still have pain often.
You must have seen the case which I shared with you, the first total ankle replacement case of India, where I did correct the malalignment, and then 6 weeks down the line, we went in and we did total ankle replacement. And that case has survived for now more than 10 years, 11 years.
That's beautiful. Have you had to do any revision at all on that patient? No gutter debridements or scope or anything?
No, there was a malunion of fibula, which I corrected and restored the length and rotation, and then we went in for the star total ankle replacement.
Yeah, it's a very, very nice outcome.
Any other question? Or we can ask Abhijit to go ahead and start with your presentation, please.
Okay, so here is a case which is a 65-year female patient came to us after 10 weeks of injury. This kind of X-ray which she had, and initially there is a history of puncture wound. Initial management was did by backslap, POP backslap, some local physician. There is a history of type 2 diabetes mellitus and history of hypertension, but patient is on oral medication and control both of diabetes and hypertension. This is the X-ray during the presentation, and soft tissue that time was heavy. So we advised the patient for a CT scan and also asked for basic investigation to show the infection status. ESR, CRP, procalcitonin, all are within the normal range. So here is a 3D picture of palm fracture, whether it is a lower end of tibia. So here is a cross section of this patient. There is a lot of comminution, as you see. So after seeing this CT scan, we plan what we do, reconstruction or fusion. But in this case, patient was not ready to go for the fusion. When she heard that there is no movement of ankle joint and all those things. But we counsel the patient and go for the reconstruction. We plan for 2 separate incision. One is anterior for fixation of the tibia, and another is lateral incision, as usual we did for fibula. So what my message particularly in these cases, that when we go for the anterior incision like this kind of fracture, we should take care of the superficial peroneal nerve cutaneous branch during the skin incision. And when we go through the intermuscular plane, external hallucis longus and extensor hallucis longus medially and extensor digitorum longus laterally, that time we should take care of the neurovascular branch, which is the tibia, anterior tibial artery as well as deep peroneal. So here is the schematic diagram through which we enter into the plane, and after that we fixed it with anterolateral plate over the tibial lower end with the fibula. There is a recon plate and there is a medial malleolus fixation of a screw. So here is the immediate post-op picture and here is a 3-month of post-op picture. So simultaneously patient has a good plantar flexion, patient had a good plantar flexion as well as dorsiflexion, but the thing is that there is a wound infection over the anterior part of the tibia. But ultimately patient is next slide. Can you
click on the screen? Click on the screen and then arrow key.
Okay.
Now, yeah.
So there is a wound problem over the anterior tibia, but it was healed within a week. So this is the X-ray of 6 months and 1 year post-op. Now the patient is there is no pain, at least right now. So take home message of this from this case, there must be must do CT scan for all the cases, and proper plan-up should be needed. How we go for further anterior, posterior, or other. Keep all kinds of implant during this operation, and counseling is very much important because in future there may be complication of wound problem, arthritis, implant failure, and infection. So this is the case from my side. Thank you.
Thank you very much, Abhijit. And this case is open for questions by panel. Dr. Dumbre Patil, Dr. Malhar, if you have some questions, Dr. Michael, if you have some questions, Dr. Abhishek, if you have some questions, you can ask these questions, your questions to the presenter. Before you start asking the question, I have a question to Abhijit. Abhijit,
Yes,
when you did the reconstructive procedure, what
yes,
did you do to the joint? So did you open up the joint? You went to the joint, and what did you do there for that comminution? How could you really get the reduction of joint through that comminuted pieces?
Yeah, there is a definite, but this case, particularly you asked for this case, or you asked for in general?
Yeah.
For this case,
Or
sir?
you did not address the articular comminution?
Yeah, we have to go definitely we have to go to the joint because the articular depression should be addressed properly. Until and unless we not address the articular depression, there will be always chance for the arthritis in very near future. So definitely, and if it is needed, we always go for the bone graft also.
Okay, so Sampath?
Yeah, I have a suggestion, sir.
Okay.
Please.
Yes, Sampath, please.
Because we have skin issue in healing, so he has addressed medial column as well as tibia through anterior incision. So we have an option, go for fibula by posterolateral approach, anterolateral approach for this anterolateral plate, because anterolateral orthotomy gives you very good exposure for the joint. Rather, anterolateral orthotomy is good for joint visualization, and separate medial approach for the medial malleolus. That would have saved your skin, because this anterolateral plate is so peculiar in placing. You take anterolateral approach for the ankle, and then for the proximal part of the plate, you take a separate incision up. So in between middle part where you have a non-healing wound, that would have been saved. So my suggestion is posterolateral approach for fibula, anterolateral orthotomy, separate medial approach, and for the proximal part, a separate incision.
Yeah, that's a great suggestion. For these cases, what I do, I like to take a direct lateral approach. And this direct lateral approach is a angiosome based approach, which is taken at the posterolateral border of the fibula, and then you're going right over the fibula, right up to the medial aspect of the tibia you can go. And this approach is between the two angiosomes, and so I have hardly had any issue of the wound like we saw in this case. And that is one of the very, very favorite approach of mine for pilon fractures. And that is what Abhishek was also discussing in his presentation. Any other faculty has any comment or any question, or we move to the next case by Girish?
It appears to be a very high energy trauma as far as the fracture pattern is concerned. Was this procedure staged or not?
Yeah, not audible.
This appears to be very high energy trauma. So was this procedure staged? Why not stage this procedure? There's a lot of axial compression into the. It must be having a lot of soft tissue problems initially.
Abhijit,
so this was already 10 weeks.
Abhijit,
yeah. Yes, I already said that there was an open injury initially.
Okay, okay, okay.
There is an open injury initially.
Okay, thank you. Thank you.
Okay. So
Okay.
Girish, Girish, you could start with your presentation. Girish, are you able to listen to us?
Girish, please start.
Okay, Girish is finding problem of his voice. So can we go to Dr. Mahesh Soni?
Yes, sir.
Yeah,
Yes, sir.
start with your presentation. Girish, you just rectify the problem and then we'll come back to you. So Dr. Mahesh Soni, start sharing your laptop, please.
Yes.
Go ahead.
Okay. Everybody is seeing this screen?
Yes, go ahead.
Yes. So I would like to present a case. So here is a case, young male presented 6 weeks post ankle fixation with this X-ray. This was fixed somewhere else. The patient presented to me 6 weeks later with this X-ray. As we can see in this X-ray, the fibula was malreduced. It was fixed by a very thin K wire. The fibular length was not achieved. The posterior malleus was fixed with 2 screws, but there was mal reduction. So these are the pre-injury X-ray. Probably it's a PER4 type of injury. The problems here are unreduced posterior malleus with posterior subluxation of the talus, fibular shortening, improper fixation of the medial malleus. So as we know, the posterior malleus reduction fixation is of utmost important. Less than 25% don't fix. It was old concept. Now the fixation has been advised by many authors across the world, irrespective of the size. Fixation indicate when there is tendency of subluxation and dislocation of the talus, even if the size is less than 25%. We have different classification for this posterior malleus, like Haraguchi classification and Bartonix classification. In both this classification, the posterior fragment was the major fragment in both these series. And why to fix the posterior malleus? Because PTFL get attachment over there and it opposes the syndesmotic instability with ATFL and interosseous ligament. In most of the ankle injuries, posterior fragment is avoided, so by fixing posterior malleus, bony syndesmotic stability is achieved. Fibular malreductions or shortening alters the biomechanics to a significant extent, as it was discussed earlier with the previous presenter, Dr. Sampath Bhai Patel. These are the various parameters which indicates the normal ankle biomechanics. So I revised the fixation with a posterior approach. The fibula was addressed by a lateral plating, and the posterior malleus was reduced with the same approach, and the posterior buttressing was done. The medial malleus was also addressed by removing the old screws, and it was fixed with 2 K wires, since this was a very small, tiny fragment with osteoporotic features. So this was the follow-up post-operative of the same patient, and this is a recent follow-up of the same patient just one month ago. The patient is doing well, and he has come for implant removal because of some limited ankle movements. As you can see, the arthritis is setting in here. So the take-home message is fibular reduction should be accurate in terms of length and rotation.
Osteomalus is an important element in maintaining syndesmosis stability and to keep the talus reduced under the mortise. So proper buttressing should be done whenever indicated. Thanks.
Thank you, Dr. Soni. One question, that how did you do the reduction of the posterior malleolus, malunited posterior malleolus? If you can describe.
Yes, I took the patient in lateral decubitus position. I opened the non-unions, malunions, removed the femoral implant first, and went for opening of the identify the cold fracture line, screws from the posterior line. I cleared that non-union side, went between the peroneus and tibialis fibula FHL, and did proper reduction with a buttress plate.
So did you osteotomize the fibula before? Osteotomize the fibula before osteoclasis of the posterior malleolus? No. Osteoclasis of the posterior malleolus? No.
Only wire was removed and the fibula was mobile.
Yeah, because when you have such a short and small posterior fracture, sometimes you require transverse lower osteotomy of fibula to reach out to that fracture. That's why this question.
So this was a 6-week-old injury only. So there was not.
Suppose this injury, this patient comes to you at the end of 12 months, 12 weeks, 3 months. You would take the same approach.
In that case, I may need some higher level of the fibula, the dissection of the fibula within the length.
Okay. Any other question from Michael? Any other question? Michael,
thank you.
Anybody has some question?
Yes, hi.
Can I ask? Yes, Michael. Yes, Michael.
So we have a Weber C fracture with the osmosis component.
Sorry, I'm not able to hear.
Can you hear me now?
Yes.
Can you hear me now?
Yes.
This was a Weber C injury. Was there a neglected syndesmosis component to this injury?
Yeah, I stabilized the posterior malleolus and then assessed the syndesmosis. It was quite okay. Yeah.
Dr. Soni, there is a question. Yeah. Did you do CT scan before doing surgery or not?
I think not. In this case, not.
But hello.
Usually I do for CT scan, but in this case, not.
But in case of posterior, sir, can I ask a question? Or
please, Dr. Kumar also wants to ask one question. Go ahead.
Yes. Thank you, sir. My question is, in such cases where revision surgery is being done, the patient counseling part is very important because you are not too sure of the outcome. As you yourself said, the patient is still having pain and there are some arthritic changes. So there are 2-3 questions. First is, how much of counseling did you do? Number one. Number two, did you have any soft tissue issues in immediate or late post-op? And third, if the arthritis is setting in, are you ready to go for some kind of fusion, or how much time you are going to wait?
The first question is that counseling part. I have counseled that patient that he is only 20 years old. So question of fusion is not here. I just explained that you require reconstruction because screws are not in proper place. Your joint is not well maintained, in well alignment. So we have to revise this fixation. He was agree for that. So the counseling was done properly. and there was no soft tissue healing afterward this thing, because it was a quite delayed, that means 6 weeks post-op, and the skin condition was good, and post-op recovery was also good. And now the pain, the patient says that I want to remove this implant because these implants are causing me pain. And luckily, the patient admitted for implant removal, and he is mentally satisfied that my pain is less. I have removed the implant just few days back. Yeah, but still I will continue with the same management. And if the pain is severe, then we can consider for orthodontist in future. Yeah.
Yes, well said, Dr. Sunil. Because the radiological changes always do not coincide with the clinical signs and symptoms. So do we ask now Dr. Girish to share his presentation?
Hello. Hello.
Yeah.
Good evening, sir. Am I audible to everyone?
You are audible. Go ahead.
Go ahead.
Okay. Yeah. So here I'm presenting one more neglected ankle fracture, which is one of the tough case in my career practice. And she's a 36-year-old farmer female. She had some history of the ankle injury 8 months back, which was treated first by the bone setter. And after 2 months of some put applications, she presented with the pain while walking. And she has tried everything, orthotics and the analgesics, for more than 5 months. And these are the weight bearing x-rays. She has, on the clinical examination, she has a pain particularly on the anterolateral aspect of the ankle. And the range of motion were reasonably good. She has 10-degree dorsiflexion and 25-degree of the plantarflexion. Regarding the osseous deformities, as you can see on the screen, and the weight-bearing X-ray, there's definitely a fibular malunion. Fibula is short, looks rotated to me, and there is also a shortening of posterior malleus, and there's a lot of posterior lateral uncoverage of the talus. At the same time, the syndesmotic, although it looks reduced on these X-ray, considering the AP and the lateral radiographic parameters, but we need to see the CT scan. She has almost 10 to 15 degree of the visible ankle valgus deformity, and also she has a limited ankle arthritis as it is visible with the joint space reduction. Fortunately, there was no hindfoot deformity on the hindfoot alignment view. Sorry, I don't have the hindfoot alignment view X-ray. And the subtalar joint was supple, and probably the deformity is well compensated by the inversion of the subtalar joint. So these are some CT images which I have, which definitely shows posterior malleus malunion, lot of posterolateral uncoverage, and as you can see on the CT, and although the syndesmotic area, it looks well reduced, but there is definitely some narrowing at the posterior syndesmosis region. There is clearly a lot of osteosclerosis and the joint space reduction, but there is no subchondral dehiscence. So I will call it as a Takakura stage 2 ankle arthritis. And as you can see, here is a medial tibiotalar space is well looking on the X-ray. So when I discuss this case with my friends and the colleagues, as the patient is young, we know it is a malunited pronation axial rotation injury. She has a limited arthritis, good range of motion. So definitely these are the 4 options which I got from the suggestions from all the side. And out of these 4 options, we'll not go in the details because of the shortage of the time, but I have chosen the realignment surgery. So I've gone medially first. I exposed the medial tibiotalar space. The medial tibiotalar articular coverage was good, and the gap of the medial malleus malunion was filled with the newly formed fibrocartilage. So I did just a deltoid release so that I can get some medial tibiotalar space mobilization. The second thing which I did is the fibular osteotomy distal to the area of the malunion of the fibula. so that I can get a good congruent surface for the closure of the osteotomy. And rather than a one plane osteotomy, here I did the open wedge osteotomy in the oblique plane, which has started from a posterolateral to the anteromedial. So this is my osteotomy line. This is how I did the opening of the posterior posterolateral open wedge osteotomy. This is what the sagittal correction I expect in the AP. At the same time, when you open the wedge, I was expecting this kind of coronal corrections, and this open wedge area is filled with the tricortical iliac crest graft. So these are my corrected X-rays, and although the ankle looks well aligned, let's see what are the parameters on the coronal and the sagittal planes. So this is the tibio-talar angle. As you can see here, initially it was 16 degree and now it has corrected, not completely corrected, but it's reasonably corrected to 3 degrees. On the another angle, which is important, as Dr. Shah has mentioned, that it is a TAL, which is the lateral distal tibial angle. Initially it was 104 and post-operatively it was corrected to 93, which is close to normal. We have compared this angle with the opposite side parameters, and what we found that the normal LTTA for this patient was 90 degree, and this is, in our case, it was 93. So regarding the other corrections, I got a reasonable alignment of the fibula, although the fibular length is not looking more than medial malus because the medial malus is also malunited, but there is a definitely Dine sign. You can see the length of the fibula is close to the lateral process of the talus, and these are some talocrural angle which is corrected. In the sagittal plane, which was the another part of this osteotomy, you can see here is that a lot of posterolateral uncoverage is now being well covered with the open wedge osteotomy in the oblique plane. The another correction which is more important, the radiographic correction which is more important, the sagittal plane, is the TLS, which was 90 preoperatively, and it was well aligned to almost 81 degree, giving good correction to sort of procurvatum deformity here. And these are the 3 months, 6 months coronal plane corrections, and this is a 6 months post-op CT. Sorry, I don't have all images because the surgery is done in the rural place. And these are the reasonably well maintained ankle range of motion at the 6 months with a good alignment. These are some literature which are showing same kind of osteotomy and showing the good results. We are not going into the details because of the shortage of times. Thank you, panel, and thanks to everyone for this opportunity.
Thank you, Girish. It was a very nicely done case. One or two quick questions. If you did not took a long leg standing X-ray, or you did not took hind foot alignment view, how would you will be able to judge about the correction?
Sir, it was the post-traumatic deformity. So I have not taken the whole limb X-ray, but definitely we have taken the hind foot alignment view. The people in the rural areas are not very trained of doing the hind foot alignment view, but I have seen it personally, and the deformity at the region of the valgus deformity at the region of ankle were very much aligned by the sort of inversion compensation deformity, inversion by the subtalar joint. So I found a reasonably well aligned calcaneum to the ankle, and I have seen this thing on the calcaneal view, horizontal view, the post-operative X-ray.
Girish,
Yes,
what is the biggest weakness of hind foot alignment view when you are thinking for correction of a malunion?
So the hind foot alignment view is basically a compensated, it is a kind of compensation to many ankle deformities. So it will not tell you about the degree of the compensation which is done, but yes, for the higher talar tilt, it is definitely has some role, and for the varus tilted ankle, or for the kind of peritalar instability, I would definitely take the hind foot alignment view more seriously.
See, Girish, hind foot alignment view ends at the level of lower third or upper third of the tibia. So that's not a good view because it doesn't give you idea of the complete axis of the hip as well as knee. The weakness of the standing view which you take, where you have a hip, knee and ankle, which we routinely take.
Yes.
The weakness of that particular view is that it doesn't take you right to the base of the or the bottom of the calcaneus.
Yes.
So that is the weakness of those views. So have you heard about Haraguchi's view? So this is the
Haraguchi.
view. Yeah, this is the view which is being practiced nowadays to know the axis of the ankle in a malunited ankle case. So this is a posterior anterior view. It is taken into the
Okay.
standing position, and it's a weight bearing full length posterior anterior view, and patient is asked to lift up the ankle. Patient dorsiflexes the ankle. So you see a complete hip, knee, ankle and endpoint of the calcaneus. And this is the view which is now used for planning of correction of the ankle malunion. So that is the
So
best view so far as it is Haraguchi's view. Haraguchi from Japan came up with this observation, and this is the view which is being used for planning of ankle malunion. Anyway, any soft tissue procedures you did below the ankle?
No soft tissue procedure below the ankle. At the level of ankle, I have mobilized the deltoid and the syndesmosis. No below ankle soft tissue release has been done.
It was not. Yeah. Dr. Sampath, Dr. Malhar, if you have any question, Dr. Abhishek Kini, you have any question, or we move to next presenter?
I think just one question. There was a huge intra-articular component to this, Girish.
Yes, sir.
You have corrected the alignment, extremely challenging one, done it really well. But I think in an intra-articular malunion, unless you kind of get into that malunion and kind of mobilize it to correct that articular incongruency, arthritis more often than not progresses, is my little experience. I think maybe Dr. Shah, Michael and all might enlighten us more on this, but I think since you were approaching it and there was a bigger posterolateral component to it, I would have gone intra-articular and tried to kind of mobilize it also. So I think this was a good case where Rajiv sir showed intra-articular valgus open wedge osteotomy for this one. So I think because of a good posterolateral.
So can I have my view on your question?
Go ahead.
Yeah, please.
Go ahead.
Sir, I will take 2 minutes only. So there's a very important question that you have asked, that why I have not done the intra-articular osteotomy of the posterior malleus. There are 4 main reasons why I have not done. First is, look at the high degree of the valgus. It was almost 15 degree of the valgus, and this much degree of the talar tilt has been associated with lot of fibular shortening. So what I was expecting is there was a lot of anterolateral soft tissue tightness as well, and I was literally worried about the interosseous tightness. And I was not very much sure that even if I do the intra-articular osteotomy of the posterior malleus at the end of 10 months of the malunion, 8 months of the malunion, how much downward descent of the posterior malleus I can get. The second point is, according to the Takakura classification, my ankle was already having stage 2 or early stage 3 arthritis. So doing the intra-articular osteotomy can further provoke the cartilage damage to this already arthritic ankle. Point number 3 is the beauty of this oblique plane osteotomy is you get a correction of the biomechanical alignment in AP as well as the lateral view. So a sort of procurvatum and the valgus deformity can be corrected by a single posterolateral oblique osteotomy, which was well described by Mark Meyerson in 2010 reconstructive foot and ankle surgery textbook. The point number 4 is, if you look at the paper by Hong Jion, which was a beautiful paper in Foot and Ankle International 2017, and the paper was second look arthroscopic evaluation and the clinical outcome after SMO. So what they have done is they have done the SMO, they have seen arthroscopically and how the cartilage is before the surgery and 6-7 months after the surgery, and what they have found that the main pain relief come from the biomechanical realignment with the pressure redistribution, and even the pain control was very good, where the minimal cartilage regeneration was seen on the follow-up arthroscopic view. And what they've concluded that even the cartilage is not looking good on the arthroscopy, but the pain relief is basically coming from your biomechanical alignment. So I've mainly concentrated on my biomechanical alignment rather than doing the intra-articular osteotomy of this 8 months already arthritic ankle.
Now, Girish, now few more points onto your this comments. Number one, no intra-articular osteotomy is going up to the articular cartilage. No plafondplasty or DTO. It do not go till the articular cartilage. You put in a wire and you put blocking transverse supra-articular wires, and these wires would bend when you open the osteotomy, right?
Yes, sir.
So coming to the principle of correction of the deformity is you have to go at the cora. You had a deformity which was in two plane. You did not went to the cora and you went away from the cora, and that because the union is there, that might sometimes lead to translation deformity. So correcting the deformity at the cora is obviously very good. Second thing, for correcting the posterior malleolus, you should have taken patient into prone, and you require to take both the approaches, posteromedial as well as posterolateral. Because when you are putting your osteotome from posterolateral, where it is exiting on medial side, to see that, you also need a posteromedial approach. So with this two approach, you should have definitely gone and corrected the posterior malleolus. You would have got the good reduction of the posterior malleolus. I would want opinion of Michael onto this case, how he would have approached this case. Michael, your views, please.
Yeah, no, I think it's an incredibly difficult case, and I commend you, Girish. I think it was very well done. My question, I think, is I'll turn Dr. Shah's question into a question: is the Z-cut osteotomy of the fibula. I was curious as to why that versus just a transverse osteotomy to allow for some rotation, and also, do you have any pearls to address the rotation? Because in my experience with the syndesmosis being intact and in some cases very scarred, it can be very difficult to mobilize that fibular component to gain length and to derotate. And then finally, how do you assess whether or not you have adequate fibular rotation? So I don't know if that was too much there, but
yeah, Girish.
Yes.
Go ahead.
So so regarding the fibular rotation, so after the osteotomy, my distal fibular fragment was totally free, and I released the syndesmosis, and the syndesmotic area was visualized to me completely. So I did the direct reduction of the syndesmosis with the distal fibular fragment, and I put one syndesmotic screw through the plate also. If you see the case, even in the CT scan, there was not of rotation problem, but even it is rotated. I have corrected it through my open reduction and good visualization. Regarding your second question, which was, sorry, sir, what was your second question?
Why step cut fibular osteotomy versus
rotational
osteotomy? Yeah. So I was reading that Z kind of osteotomy which was published in 2002 JBGS, and this was my first Z cut. Routinely I do the transverse osteotomy, but I thought that this Z cut will give me more surface area for the osteotomy closure. So that's why I have chosen it.
So as you saw in my case, we did a Z-cut lengthening osteotomy. I think it's a nice option for lengthening. Specifically, you can have those 2 points of grafting, but it doesn't allow that rotation. In particular, you had anterior to posterior translation of the fibula, which you've corrected nicely, but is more difficult, I think, in that plane for correcting with the Z osteotomy.
I agree, sir.
So can we ask Dr. Kumar to share his laptop and start with his presentation?
Right. Thank you, sir. Am I audible to all?
Perfect.
Right. So, is my screen visible to all?
Yes, go ahead.
Right, sir. So thank you so much, sir, for your kind allowing me the opportunity to be here, and I am really thankful to all my overseas faculties as well. And we had 3 wonderful cases so far from my 3 friends, Now I'm again here with one of ankle fractures. The patient, who is a young male, he came to me about a month after trauma, and the index surgery was done elsewhere. He came to me with this X-ray, and there was pain, deformity, and discharging sinus over the inner aspect of the ankle, over the medial aspect. Upon history, he didn't say there was any kind of open fracture, so whatever wound was there, it was only after the index surgery. He also with him brought few X-rays. So this is the X-ray which was there at the time of injury, on the day of injury. And then some kind of close reduction was tried somewhere, and this was after that close reduction. So it is very much apparent that the close reduction was entirely unsuccessful. And then surgery was done about a week after the injury, and this is the X-ray done 5 days after the surgery. Well, and this is the second X-ray, and this one is about 15 days after the surgery. There was a small discharging wound over the medial malleolus, and then he came to me. So from the X-ray which is there on the left side to the one which is on the right side, this was the journey thus far in a month, and there was also pain, deformity with discharging sinus. So I was confronted with this X-ray, and I went ahead and did this surgery. Now, let me accept here that no CT scan was done, and probably that was my mistake. On seeing the X-ray, I went ahead, removed the implant, and tried to reduce the fracture. Even I was not able to do, and so on close examination per op, I realized there is something on the lateral side, on the lateral gutter, and I need to take care of that. So fibula was osteotomized, and it was seen that few bony debris were there, few flecks of bone, which were actually preventing a proper reduction. Those were reduced, those were removed, and this fixation was done, and a minimal amount of external fixator was put so as to enable us to do the dressing and all. And this is after 1 month and a half of the second surgery done at my place. These are some clinical pictures at the time, 6 weeks post-op. And this is 17 weeks post-op. And now the patient seems to be doing well. These are his clinical pictures. These are his clinical pictures. So what lessons did we learn? In my view, it was planning, planning, and proper planning. As in his lecture, Dr. Sampath said that we need to understand the personality of the fracture and the patient, and then plan properly. So this was my case. Now I invite questions and any critical comment. Thank you.
Okay, thank you, Dr. Kumar. Sometimes we are posed in such a situation that we are forced to do certain innovative practices. Dr. Michael and Dr. Alan. Yeah, Dr. Mahesh Soni has a question. Please.
Yes. So this was probably a supination adduction type of injury with vertical shear of the medial malleolus. Here we expect articular impaction, and it was there in your case, articular impaction. So did you open on the medial side and reduce the articular reduction was done, or it was fixed like that only? This is a vertical shear of fracture which need to be buttressed by open book approach. You have to do the articular reduction and do a buttressing of the medial side.
Right, right. See, actually, there was infection there. There was discharging wound. So I could not afford putting any kind of plate. I was not able to put any kind of plate or a screw. Further, I was not able to reduce the fracture, and therefore I had to open from the lateral gutter as well, and then do minimal fixation with K wires and still is a steel wire. So this was a very different kind of fixation depending upon the situation prevailing at that time. So that is what I had to do.
Okay. Michael, your comments?
Yeah, I think the infection poses a problem. You've got significant soft tissue contractures, you have a wound, and you have large articular defects. I think as Alan showed some beautiful cases with the fine wire fixator, I think an external fixator in the right hands might be an option for that particular case. Would anyone disagree? Alan, maybe?
Yeah, yeah, that's a great case. For me, in my hand, I think there are a couple of situations. I think CT is critical, and especially in this case. So in this case, what prompts me to be, even if it's a simple, just a medial impact with a medial upper corner impact, and that's really an indication for a more complicated configuration of the fracture. So one of the papers from Germany, Ramet has a recent paper reviewing which kind of ankle fracture really needs CT for planning, and this is one of the indications. And also for all posterior malleolar fracture, I would get a CT scan. Or the distal spiral fracture of the shaft, I will get a CT scan because it's so easy to miss the fracture, and especially in this cases, if I remember right from the original X-ray, seems to be there is a talus, either from the talus or from the posterior mouthpiece that may blocking your reduction. So that's the only thing I want to add. And also a CT scan, the radiation amount is very safe. You compare to a chest X-ray is probably similar. So that's the one thing I would add to the comments.
Yes, certainly, I do agree that a CT in such cases are a must.
Yes.
Okay. So there's a question for Dr. Abhishek Kini by Dr. Abhishek Jain. Is that seen in your case that post ankle fusion you have a midfoot equinus? Abhishek?
Yeah, I got the question, sir. I think post ankle fusion midfoot equinus is less likely if you've done your pre-op eval better. The only reason that I can assume that can happen is because of soft tissue contractures which are affecting the plantar side. Like there is a neurological involvement or contractures of plantar tissues or long flexors which not only traverse the ankle but also go right up to the forefoot. The contractures of those structures can bring about a midfoot plantar flexion attitude or deformity, but otherwise very less likely that an ankle fusion, in which case where there was no midfoot contracture, to get a plantar contracture post ankle fusion. Like, because if your approaches are way away from the posteromedial side, the nerve which kind of supplies the plantar side, so it's unlikely. But yes, if pre-op there are some long flexors contractures which can progress, or during some manipulations where you've kind of hurt the posteromedial side, possible. But otherwise isolated ankle causing a midfoot contractures or deformities, less likely, sir. I have not seen it in my practice.
Thank you. Dr. Soni, there's a question for you, that you said
Yes,
that
sir.
your case has got pronation external rotation injury, but your fibular fracture was transverse. So can it happen in a rotational kind of an injury? That is the question.
This was not a purely transverse fracture, sir. There was some small comminution was also there. If you see the pre-op image, there was comminution. It was not a transverse fracture. It was short oblique type of fracture, and the posterior malleus was involved, so it must have been a rotational injury.
Okay. There's a question to Dr. Kumar from Dr. Hitin, that would a stage procedure been better here with just spanning initially?
No, I think that I have to go in and correct the deformities, correct the fixation. It was very important to bring about the alignment of the ankle, and therefore that was done. And to take care of the infection and to take care of the soft tissue issues, minimum amount of implant was put in, number one, and number two, a minimum amount of X fix was put so that we can keep track of the wound and do the necessary dressing and all.
Dr. Ajoy, our secretary is just silent. Would you wish to add some comments? Dr. Ajoy.
Nothing much, sir. Just that I've been listening quite long, like I always do. I listen. And there's been an excellent discussion. I don't have anything to add.
Dr. Vora, Dr. Vora,
Yes,
you want to add something?
No, sir, it's a wonderful sort of discussion. And I would just like to thank everyone for the active participation on the behalf of IFAS and invite you to the next webinars, which is on 8th, which is with Foot Innovate on Charcot arthropathy, and on 15th, the same event will continue with the malunited calcaneus fractures. And Tom Lee is going to join us for 15th of May, and I welcome you all, and we'll be just sharing the information of the timing and the event with all the guys.
Yeah, on 15th, we have Tom Lee and Go from Singapore joining as the international faculty. And thank you very much, Michael. Thank you very much, Alan. Friends, you have been very kind to give your esteemed time, and to all my speakers. And for both of you's information, we have this young emerging buddies of Foot and Ankle Society of India, who are the future of Indian Foot and Ankle Society, and they were here to present cases. Thank you very much, guys. All of you did a fantastic job. Thank you very much, and good night to everybody in India.
Thank you, sir. Thank you so much.
Good day to Alan and Michael. Thank you.
Be safe.
Thank you, sir.
Thank you
For
for
everybody.
wonderful job.
Thank you.
Thank you, sir.
Thank you.
Right, sir.
Okay.
How do we close?
I'll close it for
You just have
everyone.
to leave meeting. You can leave meeting. It's possible to do that, or